Thank you so much. It is such an honor and a privilege to be here, especially on such a beautiful day. And before I start, I brought some gifts for everybody, a little bit of bling, so I'm going to pass these around. And before I start also, since we're kind of a cozy group, I just wanted a show of hands to find out who people are, just in general. So, how many therapists are here? Excellent. How many psychologists? I'm breaking it down more formally. Okay. How many laid-out counselors? Okay. How many nurses, RNs, NPs, LPNs? Excellent. Physicians? Great. Medical students? No. Peers in recovery? Excellent. That's Jessie, right? I'm excited to talk to you. And who did I miss? What? Oh my gosh, of course. Medical assistants and administrative staff. My goodness. 2? 3. Excellent. Okay, great. So we're going to start, and I am definitely, this group knows, not techie, but we're going to try and move through this. Just to start, I'm a primary care physician by training, and I've been treating people with addiction since medical school, as all of you have since you early trained, and started off really not understanding much about the illness or how to offer care to my patients. So I kind of had to self-teach and reach out to mentors, and I was very lucky in medical school and in residency to find those mentors and in my early career. And so I've been treating most specifically patients with all substance use disorders, but particularly opioid use disorders, since Data 2000 came out. I got waivered. I was one of the earlier people and started to do this care within my primary care practice as a very young person out of training. And then through that, kind of expanded and am here today. So I have to say it's the most rewarding part of my career for those of you who aren't yet doing it. Many people who get waivered, we're really excited. We're getting more people waivered to treat people, but we're not seeing people really delve in. They'll get their certification and feel that they need more support around that. So we're trying to work to mentor people and to get people to kind of start and see that it's actually not as scary as one would think, and really congruent with other illnesses we treat within primary care. So, with that, we all know we're here because we're in the midst of a nationwide crisis, the worst public health crisis, drug crisis we've seen. Overdose deaths now have, since 2006, far succeeded motor vehicle accidents, gun violence, and now actually the peak of the AIDS epidemic. So we're in a true crisis. We know that we talk about fentanyl, and I know that today we talked about the increasing rates of overdose deaths, and fentanyl, carfentanil, absolutely involved, there's no question. But really a major underpinning, and one of the reasons that really got a nail here, is that the overdoses are symptomatic of untreated illness, and that really the needs are not met. And so really expanding access to care and really immediate care, and we'll talk about a little bit about the data as to why that's so important. Just one thing to know, and this data is a little bit dated by a couple of years, but right now about 50% of formal addiction treatment centers actually offer the medications that we know when we talk about evidence-based treatments are really the single most effective treatment to initially get people to engage in care. So half of those formal treatment programs. And even in those programs, less than 38% of people are offered these life-saving medications. And less than 5% of physicians, and now NPs and PAs, which is great, are waivered to prescribe buprenorphine. And even fewer, once they become waivered, are yet moving. The tide is moving, but we still have a way to go. As you've heard over and over, and as you all know, traditional care has been in silos rather than integrated into the medical community. We have methadone clinics outside of communities. We have addiction treatment centers, outside of hospitals and medical care. So really trying to integrate these, because at each one of these steps, from the acute care to the inpatient to the outpatient and to community settings, they're all periods when people can fall through the cracks. And so we're trying to kind of meld these together. And I know I'm probably preaching to the choir to most of you, and I am preaching to the choir to most of you because I know you are on the front lines doing this work, but just setting the stage. One thing that I can tell you about more intimately is what we're doing at Mass General. In 2012, in response to actually community outcry, it was a needs assessment that was done in our hospital where people who are served by our hospital rated substance use disorders as their #1 health concern, and our hospital responded. So for those of us who had been treating people in the community and saying we need more support, this is a really big problem, before it was labeled an epidemic, we now had senior leadership who said, you know, we really got to listen to our constituents. And so what was born was a substance use disorder initiative within the hospital, largely based in the community settings, in the primary care clinics. And one piece of that is inpatient. We have a formal addiction consult team, which just like if you're admitted with a heart attack, you'll see a cardiologist and a specialized treatment team. Now when someone's admitted to the hospital, whether they're seeking care or not, if they have a substance-related illness, our consult team will be consulted, and that is an opportunity for us to engage and start the conversation with people, again, whether they're seeking care or not. Also segues into the outpatient setting. We have addiction champions within each health center that the hospital serves, with recovery coaches as an enormous piece of that, the glue that pulls us all together, and the emergency room as well, and then the Bridge Clinic, which is near and dear to my heart, a very special place where people can receive immediate care regardless of their stage of use or recovery, to prevent that falling through the crack when they come out of the hospital, come from the emergency room, walk in from the community, or if somebody's in the health center and their team is feeling a little bit overwhelmed with somebody who's struggling, that they can come and we can kind of work to stabilize them as a team and then hopefully get them back into the community where they're most comfortable. We've heard over and over again today, addiction. There are multiple predictors. There are risk factors that we know of. It's a primary illness. It's not a manifestation of another psychiatric illness. It's its own illness. It's a chronic brain disease that's characterized by that chronic ongoing use despite negative consequences. So as my colleague says, by definition, it's irrational. And that's the piece that you're referring to, that everybody, even physicians and counselors and therapists and people in recovery, lay people, find so hard to really understand that that behavioral manifestation of continuing use is actually a manifestation of untreated brain disorder at that point. And so that prefrontal cortex that allows us to make these higher level decisions has been altered. And so we're working to try to stabilize that person so that they can then engage in the extraordinarily important piece of recovery, which are behavioral interventions, peer support, and therapy as they need it. We know that there are cycles of relapse and remission, which we'll talk about, which are very important to review. The genetic risk factor, and again, without treatment, there's no question we have multiple substance use disorders that are incredibly lethal if left unchecked or untreated. And I think the reason why we're so concerned about this right now is because every single time somebody with an opioid use disorder uses now, because of fentanyl and carfentanil, they're literally at risk of dying. So there is this special emergency with this use disorder. One thing about kind of evidence-based treatment and opinions and kind of the approach to care, when we think about modern medicine, we make decisions based on best practices, based on the standard of care, and really when somebody has an emergency, there's no question. There's immediate access, there's stabilization. We work toward remission as a goal, but not as an upfront mandate. And the severity of the illness is actually met with the treatment. And so if you think about, again, back to opioid use disorder, uniformly almost everybody we're seeing now is presenting with a DSM-5 level severe illness, right? Maybe moderate if we're lucky. So if you think about that, with heart disease, we have somebody, their blood pressure is a little bit high, behavioral intervention. Now their blood pressure continues to be high. We talk about medication and lifestyle changes. And then when it's severe and they've had a heart attack, they get everything thrown at them, a cardiac catheterization, medications, a treatment team, the whole kit and caboodle. But here, we're finding that it's kind of flipped on its head, and people with the most severe illness are really getting lack of standard of care, and we're working to kind of push toward that, and that anecdotes are extremely important, and peer support is extremely important, but we got to make sure that we're providing the evidence-based treatment. And this comes to medication, and everybody has touched on this today, which is fantastic. One thing to know, this data goes back, it's comparing and contrasting methadone access and buprenorphine access and opioid overdose deaths. So if you look at the red line, these are heroin overdose deaths, and this is actually pre-fentanyl. But if you look at the dotted line, the green dotted line is when there was actually buprenorphine access with data 2000, as you can see down in 2012. And as that took off, and same with methadone with the blue, which was around earlier, you see a steep decline in overdose deaths, 50% reduction in death, 75% reduction in crime, improvement in life. So these studies have been repeated over and over again, so there's no mystery about this. And in France, where there's no waiver needed and any physician can prescribe, there's an 80% reduction in death. And yet this medication is still highly, highly regulated. It's still very hard to integrate into primary care. There's so much mystery and concern about this because of the control and because of the lack of education about addiction. So we're working to move the dial on that. One thing about hospitalized patients, just a little bit of data. Again, it's a comprehensive approach. Best practice is comprehensive care with a multidisciplinary team. But again, first getting people in, the data points to stopping that cycle of ongoing use, reducing the negative consequences. And the best tool that we have are opioid agonist treatments. And so in the hospital, we see an 82% follow-up rate with people who initiate methadone in the hospital, whether they come in seeking that or they've come perhaps with a consequence, endocarditis, cellulitis, an overdose, some other consequence of their illness. And again, initiating buprenorphine in the hospital versus detoxing them, we see a 72% actually showing up to engage after discharge versus about a 12% if we're lucky, and it's lower as time passes on. And treatment in the ER, really exciting data from our colleagues from Yale, Gail D'Onofrio and hers. This is a landmark study. Again, very similar rates, almost 80% of people engaged when they started buprenorphine from the emergency room. Very short prescription and then followed up. And patients reported, self-report of less opioid use as well. So that engagement, getting them into care. This is more data on Gail D'Onofrio's study. And yet, again, we're having repeat studies and teams doing this work. We're finding that if you look in the emergency room, we have about 1% of emergency physicians who are waivered to prescribe buprenorphine. Again, something we're working on. You think of with the overdoses, people coming through the emergency room with emergency cellulitis after hours coming through the emergency room. It's an opportune time or urgent care. We also know that as people wait on wait lists and access is low, as they're waiting, they're dying. And so again, this is data from 2013, really before fentanyl, carfentanil took off, and just showing as people are waiting, their cumulative survival decreases. So kind of the trajectory of addiction, we know, and those of us who are taking care of people know, just like diabetes, we're not going to get their A1C from 13 to 6 within a week. Yet, unfortunately, our approach to addiction has been that if people don't get it right away, they have kind of 3 strikes and they're out, or they need a higher level of care immediately. And what we know is actually early use during treatment is expected. And so what we do and what the approach ideally would be is that with each moment that we're seeing people, we're actually seeing what this curve shows is that early use, we may see a decrease in use, or we may see that somebody's showing up. And we're going to celebrate those triumphs. And that actually helps people to stay engaged in care. In terms of maintenance, the data behind this, we all talked about this, but this is a landmark study that shows there's no question about this. repeated studies, detoxes, actually tapering people off, they're all negative studies. Uniformly, people are relapsing, especially if it's done early. And the best data that we have now is at about 5 years on agonist treatment, about 80% of people are in remission. That's better than diabetes, asthma, and heart disease. Those are the kind of the major illnesses that we compare and contrast it to. And that when we taper them in this control group, 20% of the patients died. Okay. So this kind of sets the stage for what I'm here to talk about is these flexible care models. We really need more of these flexible care models, and we'll be kind of picking up on what Dr. Carpenter was talking about today too. This is based on Aaron Fox in New York. If you guys don't know him, he's a wonderful person to know. He does a lot of qualitative research on patients with substance use disorders. And he found that individuals using syringe exchange programs actually reported that they wanted care, but they found that accessing buprenorphine was very difficult to get. We also know that there's a big concern about diversion of buprenorphine, and what we know anecdotally and from growing body of literature is that, not surprisingly, most of our patients have tried buprenorphine on the street. Most of them have tried it because they can't access care. So really, the answer to the diversion problem is improving access to evidence-based care, and we should see that go down. I'm not advocating for diversion, but this is an explanation of that to improve access. And again, barriers that patients have discussed. Inability to pay. We still know that not all treatment providers provide it based on insurance. Not knowing where to go. Transportation issues. Homelessness, clearly an issue. Having been poorly treated at a clinic is one of the top reasons. Having been treated poorly, stigma. Wanting to avoid being seen at a clinic, again, stigma. Not trusting their treatment team, and not having child care. So what is low threshold care? It's really under the model of harm reduction, the dirty word of harm reduction, which is actually maybe surprising to some, but something that you practice every single day in medicine. Really, it puts minimal demands on the patients with a primary goal of engaging the patient in care and meeting them where they are, and then helping to move them along. Really not trying to control the intake of their drugs, but talking about it. So as my colleagues say, we meet them where they are, and they'll then help move them along and never leave them where they started. It's a truly patient-centered approach. Again, just like we hear patient-centered care models for primary care, this is really analogous with that. And it's effective care. We see very good retention in low-threshold models, 88% retention at 30 days and 64% at 1 year. Comparing that to kind of abstinence-based programs, that's staggering data, the retention rate. And significant reduction in heroin and cocaine use, which is our goal, right? And increase in stable living conditions. So for our patients who are really struggling with marginal housing or homelessness, once they get better, not surprisingly, we can actually start to think about the other aspects of their lives and helping to move them into more stable living conditions. And again, low-threshold buprenorphine is really, this is an interesting thing. Low-threshold buprenorphine does not mandate, or low-threshold care does not mandate therapy. It offers it. It always offers it. It always offers peer support. But it's not mandated. Some people who have severe anxiety or have significant trauma, the majority of our patients have trauma, whether antecedent to their drug use or as a result of their drug use, loss of family connections, friend connections. And for many people, especially early on, groups are anxiety-provoking and actually triggering, and so we don't push it. And for them, what might work is more one-on-one until they get more comfortable and stabilized. And we see very high retention rates at 3, 6, 9, and 12 months. This is a newer study. I don't mean to be so data-proven, all this, if it's becoming mind-numbing, but this is what actually is very important for us to know because it needs to be evidence-based. Stacy Sigmund, this is a new study, newer study, interim buprenorphine. That's basically giving people buprenorphine while they're on a wait list, and no other therapy, nothing, because there's a wait. And what they found was actually people who were given that medication to stop the cravings, to stop the ongoing use, lowered their risk of overdose, and actually their engagement compared to at intake for people who got no buprenorphine, as you can see on the bottom, who had no abstinence. If you look, the patient at the top, almost 80% were abstinent. So the William White papers I love to refer to as well, and this is about engagement and hope. So our primary goal is to engage people, because if we can't engage them, we can't treat them, right? And hope, if we don't give people hope, then treatment is going to be very, very daunting, because this is a relapsing illness. So hope and growing aspirations for a better life can be a catalyst for recovery as much as a desire to escape addiction-related pain. And we hear that over and over from patients. Our intent is to affirm the recovery option in every encounter. This is about harm reduction approach, and to provide the support that makes this movement toward health possible, either as a dramatic leap. For some, it can be, but mostly as a process involving incremental steps over time, and that's what we see. This, I don't know if you can see, this is actually, we have a little book at our check-in, and one of our patients who is now doing very well, she's in sustained remission from her opioid use disorder and is struggling with cocaine and alcohol, engaging. She comes in almost every other day, and she left us this note, which is what we hear and is probably the most poignant thing, I think, for a medical illness, that she's thanking us for the respect and kindness that we have for all the people that go through here. I love you, Whitney. And that's something that people are saying over and over again. I don't remember the last time I said that to my primary care doctor, but that shows you that this is a unique experience for people, and it really shouldn't be. It should be kind of a standard approach to any medical illness. So, questions about that before I go on a little bit more to the model, because I know these are long talks or concerns. Okay, we'll go through. So let me tell you about the Bridge. This is our mission statement. The Bridge Clinic bridges the treatment gap, and we sat down and did this together by providing on-demand compassionate care to patients at all stages of addiction. And we're a specialized multidisciplinary team. We're a tiny team, and this is something that I think could be replicated very easily. It is a recovery coach, a peer who's in recovery herself, extraordinaire, a patient service coordinator, our administrative assistant. We have a resource specialist also in recovery herself, me, a part-time psychiatric NP, and a PharmD who is very interested in addiction. So there are 6 of us. And we basically, everybody who's there is there with the same mission. The treatment starts from the minute the person walks in the room. The patient service coordinator meets them, welcomes them, is happy to see them, whether they're a week late, whether they're an hour early, whether we don't know who they are. The initial approach is, we're so glad you're here. So it's a specialized multidisciplinary team. It's an immediate access and a transitional clinic, and that's how we're able to keep the immediate access up. And this is the hardest part for us and for the patients, because addiction treatment is all about engagement. And so that kind of disengagement is something that's a work in progress, and we're trying to figure out how to segue people so we can keep up this urgent access. But it's for patients who need care but lack community services, or, as I said earlier, are engaged in community services but might need a slightly different approach to care for a period of time until they can stabilize. We do drop-ins, so walk-ins or scheduled appointments, and we say scheduled just because we have a heterogeneous group of patients. Some people are working, they have to get their kids, so we try to do scheduling, but the idea is it's always followed up with, if you're going to run late or you can't make it, it's okay, just come when you can. And the reason for that is because early on, or if people are struggling, it's really hard to manage all those executive functioning. So it may be difficult for somebody to get up to an appointment at 9 a.m. and then be told if they show up at 9:30, sorry, you're done, and then they have to go out, and with such a high risk. So we try to keep that flexibility. So we discussed engaging people, so meeting them where they are. If they've been told by previous treatment providers, you really need a residential, and we know in our head they would do great in a residential treatment program and then step down to an IOP and then to another program and then to a halfway house, but they're not able to do that or ready to do that, then we're going to go and say, where do you want to start? And we're going to start there and then help to move them along. The other thing that we do is we do addiction pharmacotherapy, as you can imagine, based on what we just talked about. And I'll talk a little bit more about how we manage that. The peer support is a critical piece. We have individual and we have groups. We have kind of casual groups. We have a I Hate Groups is what they've named it. It's an art group. They put on music, they have snacks, they do some art. We have a lot of very artistic patients. We have a wall coming out of graffiti, and it's great. And then we have Tuesday, co-led by our recovery coach and our pharmacist, more chronic disease of addiction model, and then a more traditional peer check-in. And we're bringing a family group in, which is going to be key. And then an amazing nurse came up the other day and said, I do mindfulness and yoga, and I can't believe how many patients you're taking from the ER. I just want to volunteer my time. So we're going to start that on Fridays as well. Narcan training as well, harm reduction strategies, which I'm happy to talk to people about too. I know that there are a lot of people who are already doing that. Advocacy, HIV and Hep C testing, and then this consult and return model. If our colleagues are starting up as new providers or have a patient they feel like they need a little bit more support, we'll kind of share and work there. So why is this unique? Because it really is on-demand care, urgent access. We do same-day pharmacotherapy. As I said, warm welcomes and warm handoffs. And the other thing is deconstructing the relapses. This is part of kind of treating people with addiction or any illness is, okay, let's break it down, what led to this, and always finding the positive in a relapse. So when people leave that room, they're leaving with a sense of hope, that there's something in that that's going to keep them coming back and see that they're making progress. Patient education and support. We'll take care of patients who've been in and out of treatment programs, and they're up to their eyes in IOPs, and yet they still haven't been able, because they've been so uncomfortable or sick or not aware, where they really need to kind of get down to the nuts and bolts of what's going on. And so where that is, it could be one-on-one, it could be with groups. So we try to do a lot of education for the patients and not just assume that they know all of this. And motivational enhancement, obviously, is a key piece to the treatment. Trust. Cannot do this work without having trust and having them feel that they can trust us. And then really the biggest piece is that no one is discharged for active illness. So if people are using, that's understood from the beginning and they're told that. The whole idea that they're here is for treatment. And if people are struggling, that's actually a sign to us that we need to figure out a better treatment strategy. And so we work to find that together. So this gets back to what we're talking about, the traditional expectation that people will get better, and we know this is what really it looks like. This seems very glib and obvious, but when we transpose it onto more traditional treatment models, that's kind of lost in the mix. So we're trying to kind of bring this back. Reducing negative consequences, also another euphemism for harm reduction. So congruent with every other chronic disease that we manage. So if we think about diabetes, we worry about end-stage complications of poorly controlled diabetes. And we talk to people how to manage that. Same with heart disease. If people are smoking, we talk about trying to quit smoking or moving them along or their diet and exercise, but we don't avoid it. Same with people, and I'm specifically talking about injection drug use, we talk about safer substance use, how they can keep themselves if they're not yet ready to stop, or if they are kind of moving along there, how we can keep them safer. So talking concretely about safe sites, talking about how to use clean needles, how to use clean works, going through. If people feel like they need works, we do that. And then also intranasal Narcan distribution and education. And then a harm reduction approach, obviously, is immediate access to pharmacotherapy as well. Narcan, this is from a patient actually who's still with us, and he's doing phenomenally well. He comes by about once a week now. He had an overdose. He came to us and he left us this message actually the day after his overdose. He's so grateful for his family, his health, the program, and his message that, did I leave it out of there? He had said something that a grateful person will never relapse, which is not the case, and he did relapse, but he continued to do well and stayed engaged. But this is just a piece for just that Narcan is very important and is saving lives, and unless we have it, we don't give people an opportunity to get into care. So contingency management, another evidence-based strategy to help people engage in care and stay in care. We don't do it formally. We have coffee, we have snacks, we have clothing donations for our homeless patients, we have a computer and a phone. Our resource specialist does a lot of the heavy lifting for people. What we don't do is give people a list of places to call. We actually help to do that, just like we wouldn't give someone after they've had a heart attack a list of cardiologists to call. So we're trying to unload and lower the barriers of care for patients. As I said, art therapy, we have these little tokens we made, and then really the most obvious and easiest one is kindness, and that's free. The referral resources, if you were going to start your bridge clinic, I would recommend that we start very slow. That's what we did. We started with a tiny pilot from the emergency room and from the inpatient addiction consult team, where we were seeing people after hospitalization, they needed ongoing engagement and care or medication and had nowhere to go, so we'd bridge them. Emergency room, post-overdose patients, we'd see them that day, get them kind of stabilized that day, and they come back the next day. And now we're hospital-wide. So right now, we've had 4,039 visits in the past year and a half for 459 patients. So that gives you an idea of how frequently, and I'm sure you can relate because this is about complex patients. These are complex. The majority of our patients are homeless or marginally housed, psychiatrically complex, medically complex. 80% had a same-day visit, 63% had a walk-in, and we've seen about 85 at this point patients directly from the emergency room. The rest are from, as I said. And in general, people are staying about 2 to 3 months, and of course we have outliers on either end. In our no-show rate, this is the most recent one, and that's with an asterisk because we don't do traditional scheduling. We say, here's your appointment, but come in on Friday if you can't make it, et cetera. So this we're trying to tease out. We suspect it's lower than this, but it's 18%. And again, if you think about traditional models where it's more 50 to 60%. Sorry. Okay. So, questions? Concerns. I brought some patients with me. Yes? Great question. So we have the luxury and the incredible support from our president, Peter Slavin, who, again, in response to that community survey, has actually been supporting us financially. So we get money from that. We have a SUDS initiative, and the Bridge Clinic is part of that. That said, I still bill for our visits. The majority of our patients have a Mass Health product, but we take people regardless of their insurance, regardless of their inability. We have patients who are coming from other states, and we're trying to kind of work that in and figure that out. We have some philanthropy, not much, but it's embedded in the hospital budget. And again, that came out of, again, the response. It's also, we're showing there's a financial benefit for the hospital as well. We're keeping people out of the emergency room. We're keeping them out of the hospital. And that's actually our analysts didn't have all that information for me today. But I think the latest was a 10 or 15% reduction in repeat emergency room visits. Again, this is, rudimentary numbers, but I can follow up with those. So there's a benefit. Yes?
Are you doing observed dosing, or if not, are you doing short?
Yes. Yes. Yep, so that's what we're going to talk about. So how we do it is If, for the majority of people, we know, so they're coming from the hospital, so they have a diagnosis already from our addiction consult team. We have toxicology, emergency room, they come in with an OD, or if they come off the street and they have stigmata of addiction, or they're kind of known to us. We have the diagnosis. And so what we do is, and again, gets back to the majority of our patients have either been on buprenorphine, have been taking street Suboxone, and quite frankly, a lot of them know how to do their inductions better than any of us can do in office. And I would say the majority of us who've been doing this, I can't remember the last time I did an in-office induction. Most of us do home inductions. And I can share that we have Josh Lee's, it's actually a validated tool that's now being used and given out in buprenorphine trainings for home inductions, just walking people through it. So what we do is we give them a very short script. We don't have them wait because, again, many of them come in and either they've recently used or it's too soon, and they may go into withdrawal enough to dose in the middle of the night. So we want to get them started. So we'll give them 2 to 4 films to take a prescription, and the majority of them are coming back the next day. So we'll say, just take this, and we talk about when to dose, and they show up, and then we go from there. So we'll do a tox screen that day. We do oral swabs in our clinic, A, because we don't have access to a bathroom, but B, because it's, we're kind of rolling those out to the health centers, and we've been using those, and it's been great, and those are directly observed. And then how frequently we do those is based on kind of the patient. We don't do a tox screen every single time. We check and see that they're taking their Suboxone periodically. But if someone's coming in, and again, that gets back to the trust and feeling open, and they say, you know, I'm really struggling with the Coke, or I used yesterday, I'm going to think, do I really need to do this tox screen? It's going to change my management. I did one, you know, a couple weeks ago, and they're coming. We're doing very short scripts. We do weekly scripts. And that is, the first one is a kind of a 1 or 2 day script. The longest they'll get on initial visit would be 3 if it's on a Friday for the weekend. Then they come back Monday. And part of that is we have a couple of people, say they're in New Hampshire, they're with their parents, it's very hard to get up here, they're otherwise plugging in. We'll do a longer prescription. But by and large, it's weekly. And part of that is also because then it's really hard for us to plug people into long-term care as well. And then we're going to become, you know, a long-term clinic, which then will not allow us to keep up with the mission of doing this urgent care. Yeah. So.
I was wondering, do you allow people who are impaired to come to your clinic, and what's your policy about that?
Yeah, thank you for asking that. So yes, we do. They come at any stage, and it's interesting. We've had one person who went to group impaired, but the majority of people, if they are, I'll kind of pull them into my office, and we'll kind of keep them out of the group, just because it can be triggering for other people. But yes, they come in impaired. We want to get them to come in at any stage so we can work to engage them. We want them to feel safe. Okay, so we could do some cases. All right, so who are the patients? So we have definitely short-term stabilization. We have people who transfer. I'm thinking of one person who came, he transferred to the area. He's an investment banker. He couldn't find a buprenorphine provider. He had a short relapse, showed up to our emergency room asking for care, and he came up, and he was with us for about a week and a half. So we see that until we plug him into a longer-term program. Low threshold care, these are the majority of our patients. Homeless, as I said, some with chronic mental illness, large trauma, special populations, pregnant. We're seeing more cancer patients with complex chronic pain needs, and then post-incarceration. So those are patients who are going in and out, maybe picked up on a warrant and come out, or coming straight from release. And we're really thrilled about that because that's one of the highest risks of overdose time. But that low threshold care we can talk about, because I know that's a piece that you all want to hear about. So this is Ryan. He's a 30-year-old man with severe polysubstance use disorder, primary opioid, Not surprisingly, he has post-traumatic stress, ADD, major depression. He's been in and out of the correctional system and DYS since he was a little boy, sectioned multiple times, multiple ER visits, multiple overdoses, and complications thereof. And he actually came to us, he stabilized very well for a few weeks, connected with our recovery coach, then was lost to follow-up. He had multiple relapses, had stepped up his using, had multiple complications, and this was about a year ago. We continued to kind of be there when he'd show up, work on kind of motivational enhancement, moving him along. When he's really impaired, it's hard to do that. So we wait, and then he'll come. And now, actually, as of yesterday, we saw him yesterday, and he's actually stabilizing. He's been in remission for about, what did they say, about like 8 weeks, which is great. He's engaging, and he's actually planning to go into a residential treatment. So these are, in kind of the traditional model, small triumphs, but these are enormous triumphs for somebody with this history, and he's moving along, and recovery is happening, and it might just be that circuitous route, but this is a very successful transition. This is someone who was with us every day for about a year ago. Goes back to the statement, you got to rethink the treatment if it's not working. It's not the patient that's failing, it's our treatment approach, and how can we meet them and figure out a better approach. How can we also make sure that we're not missing co-occurring psychiatric illness, making sure that we're treating that as well. And I would say also with homelessness, the elephants in the room, people, places, and things. I mean, there's open-air drug use all around, so it's an environment wrought with triggers, even in the best-case scenario. So I'm not saying this to sugarcoat that this is an easy fix. Relapse, as I said, reframing it as a learning experience, breaking it down, emphasizing that we're going to continue to work together until we can find a place that they're comfortable and we're moving along, and continuing to be positive about this. For an example, these can be minor things. If someone has actually stopped shooting in a very dangerous area, their neck area or their groin area, and now they're using their hands, okay, that's a step. Or if now they're coming to see you and tell you that they're struggling with using, that's a step. So these are positives. You got to find the positives in the relapses. One thing about higher level of care, because I also work in a more traditional program as well, which is a higher level of care. We have a residential, and we have an IOP and a step down. We have the whole continuum, which is fabulous. But when we recommend higher level of care, it can often mean no level of care. So again, that goes back to what is the patient able and willing to do financially, emotionally, physically. And when we say you need a higher level of care and then they're lost to follow up, that's nothing. Or if we send them to a treatment facility where, say they've been doing well with, this comes up a lot, they've been in remission with opioids on their Suboxone, struggling with cocaine. You recommend a higher level of care. They go to a wilderness program or another program. They're taken off of their Suboxone, and now they totally destabilize. So you just have to know when you're recommending higher level of care what that means and where you're sending people. And higher level of care can be done right in your office. So you can do shorter prescriptions. You can do bringing in more team members. You can, do closer interval follow-up. Adjusting the dose. Is the dose subtherapeutic? Really kind of looking at the comprehensive care, and you can do it in your office before you say somebody needs to go somewhere and then potentially lose that incredible trust and having to restart again. And then talking about shifting gears a little bit for reducing the harmful consequences. This is a journal, some of you guys probably have this, a magazine about that you can give. I think it's great. Medical facts, injection techniques, junkie wisdom and common sense strategies. This was made by providers and people in recovery, people who are using, excuse me. It's a safety manual for injection drug use. Okay. David, this is someone who's been with us a while. He is street homeless, severe opioid use disorder. He has a traumatic brain injury, and he came to us on referral from a friend. Stabilized beautifully on buprenorphine. Groups were really difficult for him. He just couldn't do them, so we backed off. He continues to come twice a week. He's working part-time. He's now just started a little SSRI and finding that he's a little bit more comfortable. He's continuing to use K2, and we're working on that. But the success with David is that last winter, somebody had given us boots, winter boots, and that was something he really, really wanted and needed, and he got them. And when he got them, he decided to use some of his money to go into a hotel room, and he took a picture, and he sent it to us and said, this was the first time I didn't spend my money on drugs. I went to a hotel, and I have boots. And that was kind of a big step for him in terms of trust, so these tiny things. And he is in sustained remission from opioid use disorder. So his risk of overdosing and dying and having consequences has markedly decreased, and he's engaging, he's getting his life back. So we're working on that. So redefining what you're hoping, what is recovery. Stephen, another patient, I don't know if you can relate to this. This is another patient with multiple psychiatric complexity. He came to us after an overdose, stabilized actually he needed really significant co-management with our psychiatric team. The peer coach really worked with him almost daily, checking in with him, going to have coffee with him, going to court with him, advocated, and he had short relapses along the way, stuck with it, multiple kind of ER visits, and now he's back, he's doing construction work, and he's staying engaged. And this is the transition point that we're looking to kind of figure out, and we're struggling with. He's been with us, he's doing so well, this low threshold model has worked for him. Trying to find the next step is where we're all struggling. So that's the biggest piece now. How am I for time, Erico? Okay, so I'll just, this is a pregnant woman. I don't know if you guys want to hear about it. Very similar situation of kind of low threshold care, partnering very closely with her OB team, and working. Now we've been able to move her into residential, whereas before she was kind of jumping out of programs and couldn't get there. And as her pregnancy moved along, it became more and more critical that we get her in. So this goes back to, I think, what Dr. Carpenter had said, that really getting as best we can to empathize with our patients. Don't hate the addict, hate the disease. Don't hate the person, hate the behavior. If it's hard to watch, imagine how hard it is to be living it. And I think that's the key that we have to continue to remember, and really trying to just look at this illness through the lens of other chronic diseases that we do every single day, and being flexible when there's an emergency, and there's nothing more emergent right now than this illness. Trying to be flexible, very short prescriptions, open communication, positive reinforcement. Interdisciplinary support is critical. And also following up with phone and FaceTime is very helpful too. If people aren't coming in, you're not able to, that's another way you can reach out to them. We do regular all-team meetings and huddles, which are critically important, and I put self-care in there. This is incredibly trying work when we worry about patients, as well as incredibly hopeful and positive work, but it's important to make sure that everybody's okay and feeling they can communicate about concerns. And developing community relationships like today. I love this slide because this is, even if we can't necessarily all walk in the shoes of our patients, it's very important to at least try. So you might, we haven't done this yet, but, and another message from one of our patients who's doing very well. And I think that's it. Oh yeah, giving hope. I think that's about it. Okay.